But you'd be surprised because, you know, you think about the ribs, like how many people come to you with a diagnosis of the rib. But, you know, any thoracic, shoulder, cervical, like the rib cage is super instrumental in all of that. So on your little diagram here, I don't want to confuse you guys too much, so I want to make sure, I want to go over like just a few definitions and make sure we all have a really good concept of the definitions of the anatomy. I know it seems super basic, but we're going to be talking a lot about anterior on the chondrum and the sternum, so I want to make sure that we get those definitions right. So if you look at the chart, so the top half is basically everything that's going to be on the right side. So the bottom half is just the same, it's just reversed for the left. So we're going to focus on just the top because obviously it's just reversed on the other side. Does that make sense? So not to confuse y'all too much. So we have the chondrum, which, as you all know, is this kind of piece of cartilage here. This part of the rib here is called the chondral portion of the ribs. And then obviously this is the sternum. So the way that there's four, and Bjorn talks about, he calls them lesions. There's the 4 different lesions. So the lesion can happen here at the sternochondral junction. It can happen at the costochondral junction. And then it can happen back here at the costovertebral junction. So it can be out all different kind of ways. The main way that I've taught most of you is only anterior posterior on the sternum. But there are other lesions, they're not as common, but they are rare. When people come in with like this hurts right here, learning how to mobilize on the costochondral junction can make a world of a difference for patients. So that's what I kind of want to review with you guys today. If you look at the first, so it's the first like box, rib angle posterior prominence. So it talks about increased or decreased. So what he means by there, and if you want to go ahead and write this in, it might help you. When the right is increased, it's talking about it being posterior. The angle is increased, so it's more prominent. So posterior. So where it says increase, just write posterior. This kind of helps my brain a little bit. And where it says decrease, just write anterior. Or if you can, if you're really smart and you can remember that, then have a good memory, then go for it. Then we have the costochondral step off. So that's the step off that's going to happen right here on all of these guys. Then we have the costosternal step off, which will be here. And then so it talks about where the lesion location is, and then of course the latter part of that is where our fist is going to be placed, like where our hand's going to be placed for treatment. So if you look at the 2 middle ones, those are the most common. Those are the ones, the lesions that happen only at the sternochondral junctions. So basically you have all the ribs are forward or all the ribs are back, anterior or posterior. So that's what we're going to go over first. Trying to see if there's anything else. Oh, before we get into that, I want to all have an agreement. We can do it either way, just on how we document this. So you can document it 2 ways. You can write like what the lesion is, so like muscle energy, neuromuscular reeducation to correct for whatever the problem that you're seeing, or we could document it neuromuscular reeducation to facilitate X, Y, Z. What do you say, QA director? Do you think should we document it to what we're facilitating, or is that going to make it too confusing? No.
I usually document it so that somebody can repeat it after me. So I'm not usually saying to facilitate this. I usually write it like an NET to correct
what the actual lesion is. Okay. So y'all are good with that? Okay. So if you put, for example, if we're talking about all of the ribs are anterior on the sternum, you'll say muscle energy technique to correct for right ribs anterior on sternum. So because now we're going to be talking about the chondrum too. So you just writing right ribs or anterior is not as specific as we want to get. So just kind of adding that to it. Okay. So that's how we're going to document.
I'll also say too, if it's like that protection of the muscle.
Yeah. So I'll usually write like upper, mid, or lower. just a few things to note too. I don't know if you guys have ever noticed this. And for some reason, I see it mostly with the third rib. Have you ever like looked at if they're anterior or posterior and like there's one rib that's just like sticking out a lot? So in that case, you can, what I would suggest is doing a mobilization on that rib specifically. So instead of taking your fist and putting it here, you'll take it with your thumb straight and put it right on the rib. And it hurts. It'll hurt them. So just be like, this is gonna be really tender, and then you have them do that. Like a lot of times too with those, I'll have them breathe to facilitate as well. So take a deep breath in, and then as they exert the force, they're exhaling. And then if I look at that, looks a little more normalized, and they're still like anterior everything, then I'll do another more general one where it's just that. But that one can be really helpful, especially for patients who will have pain here, but also like pain between the, between the shoulder blades, like kind of that space between there. A lot of times that can cause pain there. Okay, so let's go over the anterior posterior. Who wants to be my subject?
Anybody have anything wrong?
I probably do. I'm most likely to.
Come on up.
I'm like, I probably have some. I've been doing a lot of rib corrections, so that'll probably help.
So let me see, let's come in the middle so that everyone can kind of gather around the next one. Face this way so that the video hopefully can see us.
It is. The
Yeah.
video is pointed perfect.
Okay, good, perfect. All right, so a couple of ways to determine where do you go first, because I know sometimes it's hard. It's like, do I treat the right side, do I treat the left side? Where do I, they're all forward, where do I go? So there's two ways you can determine that. My favorite way is the area of greatest restriction. So, and this takes a little bit of time to develop, kind of hone in on your skills to feel. But what I do is I come, I'm just gonna go on this side just so the camera can see us a little bit. I come and I feel kind of with this side, that my feet are eminence, but more kind of my thumb. I want to get my thumb in there just because that's where more sensory is. And if this makes sense, feeling with your hand and not your head. So you're going to feel a lot more that way because it's just the sense of touch is going to give you more feedback than if you're trying to think about it with your brain, right? And think about too, if you have a surface kind of like this, like let's just use the table for example. If your force is too hard, like say I push in and then I try to feel for the restriction, I'm not going to be able to feel anything. So just make sure that your force is fairly light so that you can feel the pliability of the tissue. So I'll just take my thumb and kind of give a little bit of side bending and extension rotation here. And think about too, the rib angle. You want to come on the area where the rib angle is the greatest, so you can feel and see more, but the rib angle kind of goes out a little bit lateral as you go down. So think of it like an A. So I'll come here and just kind of feel. And then come on the other side. And sometimes I have to do this a couple of times just to, and what I'm feeling here is this feels more restricted than the other areas. And again, it's just like instead of a nice springiness of the ribs, I get like I'm pushing the wall, so it's harder. Another way you can do, and I'll go over that now, is measure with any inclinometers around here. The other way, sometimes it's just hard. Because people are guarded. Sometimes we have off days where we're not as, like you're just not as in tune as you normally are. Is measuring scapular rotation. So I take the medial border of the scapula, and you don't want to put the inclinometer directly on it because you can tend to move it. So I like to put my fingers there and then lay the inclinometer flat against it like that. And then we'll zero it out. Tap it a couple times so it doesn't stick. Okay, lift both arms up as high as you can. You want to make sure you zero it out too, because some people's shoulder blade sits differently than others. Okay, so Jess, you've got about 48 degrees on the left. And I'm going to measure the right. So practice this with your patients, your thoracic, your cervical, your shoulder, definitely your shoulder patients. All right, put the cards together. So I can already tell that one's not moving as much. 32 degrees. And that's our found restriction. You're not always going to see a correlation that way, and that's okay. Okay, so I'm gonna focus on this side, which is good because we're working on the right side here. Okay, so I'm gonna come here. Now, does everybody know what eye is their dominant eye? Who does not know what their dominant eye is? Okay.
I figured it out. I figured it out yesterday.
Anybody? Everybody knows what their dominant eye is? Okay, well, we'll do that real quick. Okay, so find something straight ahead, be a clock or something like that.